My name is Ameena Zia. I am the founder of Blue Ridge Impact Consulting. We are a social impact firm working across private and public sectors to ensure a stakeholder approach to development. I have been engaged at the UN civil society space since before the global goals were adopted in 2015 by over 180 world leaders as the framework, as the guiding tool to achieve sustainable development. I'm very excited about the work that we are doing as a community and as we continue to recognize the shortfalls of technology and in healthcare space, and also work towards challenges to the future with innovation and technology in mind. At Blue Ridge Impact, we are rooted in the multi-stakeholdership approach to policymaking, which aims to bring together primary stakeholders such as yourselves. We bring in businesses, civil society, government, research institutions, and non-government organizations to cooperate and participate in dialogue and decision-making and to implement solutions to common problems and goals. And I'm very excited about our dialogue today because we are engaging in a conversation to help dive the conversation in Florida about what is the social responsibility, what is the social contract of stakeholders within our communities and within our professional spaces. And this conversation is something that we spearheaded at the United Nations as part of the Agenda 2030. Which is a global framework that has been recognized as the blueprint to move forward as we try to address challenges that act as barriers in ensuring that everyone has access to healthcare. As a social impact firm, we are heavily rooted in the UN Global Goal 17, which is partnerships, and which is the reason we are all here today. As the US healthcare system we know continues to evolve, one of the key areas of influence is the coordination and administration and delivery at the local levels, right? And so in order to ensure that all our communities are included, there is this increasing need to focus on, are we able to deliver the kind of care and have the kind of impact that cuts across all communities. With an increasing consolidation of local healthcare systems that we're noticing, we must ensure that partnerships, mergers and acquisitions, and of course, interconnectivity of regional healthcare affiliates is responsive to the shifts in needs in the focus, of the delivery of care. Today's dialogue is focused on Florida, and it hopes to spark a substantive conversation about the rapidly changing society that we find ourselves in. And we hope to examine the balance between national trends with state and local trends. We hope to engage in regional market level systems and how they're reshaping the delivery of care, and also shed light on perhaps considerations and roadblocks that exist as barriers. And we believe that in harnessing a collective power to stakeholdership approach in addressing local problems, we can find solutions to some of the barriers and try to bridge some of the gaps that we find. Especially right now, we are finding ourselves in a strange space, in a strange professional space, as we're all trying to navigate the COVID-19 pandemic, its response and its recovery efforts. So the question that we hope to shed light on today is, what is the social contract between providers and consumers of telehealth, which has been recognized as critical in building bridges. And we know that health disparities are driven by inequities found in healthcare systems. And when we add other social and economic inequities, including economic stability, neighborhood and physical environment, education, food, community safety within the social context, we know that the outcomes and mortality, morbidity, life expectancies, health status, and even functional limitations manifest into the health and well-being of individuals. And of course, then they translate that into communities. And so this is the reason why we feel that having stakeholders, such as our panelists today, to discuss the intersectional approach to responding and reducing barriers is very necessary. And we also need to examine the broader range of disparities within the dimensions found across socioeconomic status, age, geography, language, disability status, citizenship status, and sexual identity and orientation as well. We know that analysts have estimated that disparities amount to approximately $93 billion in excess medical costs and $42 billion in lost productivity per year. And in order for our economies to stay competitive, we must address these persistent gaps. And so our intersectional discussion today is not only inspirational, but also a significant dialogue that holds a lot of value because it recognizes inequities that are linked to social, economic, and environmental disadvantages that do adversely affect people who have been systematically experienced greater obstacles to healthcare. So we need to understand that there are structures, policies, practices, and norms that assign value and determine opportunities, and all of which, of course, place vulnerable communities at a greater risk for poor healthcare outcomes. I'm looking forward to the inputs from our panelists today, and at this point, I think I would like to lay out the structure of the discussion. I will begin by introducing and yielding the floor to our partners in Florida who are working within their respective professional spaces. And I invite them to tell us a little bit about their organizations and some overarching thoughts about social contract between telehealth technology, as we have recognized that it is a solution to help bridge the gap in health inequities, and also our providers and consumers. I would like to mention that in putting this panel of experts together, our partners have been instrumental in navigating and identifying stakeholders in Florida for this very important discussion. With that, I would like to yield the floor to Lloyd Sirmons. He is the director of a very active Southeast Telehealth Resource Center. Lloyd, at this point, you have the floor.
Hey there, thank you so much, and thank you for allowing me to participate and to to be a part of this particular event. And it's always just a great opportunity to share when we have the opportunity to share about what we do. And so I am the director of the Southeastern Telehealth Resource Center. We are one of 14 federally funded telehealth resource centers around the country. We are funded through HRSA, which is the Health Resources Service Administration. And our purpose really is to advance telehealth across the country. That's what we're funded to do. And so I have the pleasure of serving Alabama, Florida, Georgia, and South Carolina. Those are the states that I serve. And we try to advance telehealth through a number of ways. One of the major ways is through education and outreach. So we do a lot of webinars, we do a lot of speaking around telehealth and telemedicine, but we also provide technical assistance. And that's one of the reasons that we're funded, so that when people are looking to get into the telemedicine space, or maybe they have a telemedicine program and they have questions around policies or legislation, reimbursement, those type of things, then we actually serve as a resource for those people. And we are we're a free resource. So when we start talking about social contracts and serving people, that's one of the things we do on a daily basis. And so being funded by the federal government and being kind of placed in this position, it gives us the opportunity to work with a lot of people, various backgrounds. We work with health systems, we work with education institutions, whether that be education institutions of higher learning, or like high schools and those type of things, local education departments. We work with physicians in small practices, physicians in large practices, and really at the end of the day, our goal is to advance telehealth and telemedicine and see that it moves forward as it should. The neat thing is each one of the states that I work in is night and day. They're totally different when you start looking at that telehealth landscape. And so sometimes keeping track of the policies and and those type of things and reimbursement can be very difficult, but it's just something that that we do. And I think it's really neat. I mean, this conversation comes at a very good time, because when you start talking about what is the role in ensuring that people have access to healthcare and to good quality, high quality healthcare. One of the things that I think COVID did is it shone a light on the fact that when you start looking at accessing healthcare and bringing healthcare to the people where they exist in their homes or at work or what have you, especially in a time like a pandemic, one of the things that I think we realized that we had not really given a lot to a lot of thought to was the issues around broadband. And so so often we didn't think of the two, being together or joining together somewhat. But that's one of the things that we very quickly began to realize was that people who can't access, who don't have adequate broadband, they can't access healthcare. And so when you start talking about telehealth and telemedicine and using technology in the healthcare field, one of the important things that has to be looked at and thought about, and we're seeing that more and more now, is the whole issue around broadband. So I think this conversation is timely. No doubt we're going through some great changes when it comes to healthcare, but then that whole technology field and moving into the whole broadband conversation as well has been very big too. So I'm looking forward to the conversation, and if I can ever be of assistance, please feel free to reach out. You'll have all my contact information.
Thank you, Lloyd, very much. Our next partner is Sarah Sorry, Sarah, I told you I would work on that.
You're good.
Our next partner is Sarah, representing the Florida Rural Health Association today. Sarah, we would love to hear a little bit about what your organization is doing and your thoughts on the social contract.
Thank you so much for having me. My name is Sarah Catalanotto. I am the Association Manager for the Florida Rural Health Association. We were created to provide a mechanism through which interested individuals and organizations in Florida could unite in advocacy for ensuring all residents of rural Florida to have access to a continuum of affordable healthcare and healthcare options. We do this, our tagline is One Voice Louder. So together as an organization and as a membership association, we ensure that we are understanding what's happening within our rural communities as it relates to healthcare and health access, and find a way to speak for them on behalf of those individuals. We have been around since the early 90s as an association. Our membership is normally from rural stakeholders, from rural health providers to nonprofits to decision makers within our rural communities and our healthcare. We have great partnerships across the state of Florida. And when the conversation about telehealth came about for this conversation today, we just felt like it was important for us to be here. We see ourselves as a clearinghouse. So we keep our eye and our ears out of what is going on within our rural healthcare communities in the state of Florida, try and identify those issues, and then be a clearinghouse of information or resources or connection to individuals with potential solutions or assistance. When COVID hit, our biggest thing that we were hearing through our rural providers was access to healthcare for our Floridians who are from our rural and underserved communities. And through that, telehealth was that solution. But we have learned through what Lloyd was basically saying is that there are still challenges. And I think that most of our rural providers did a temporary solution for telehealth, but now there's this intent of making this a permanent option for delivery of healthcare access. But then how do we make this more equitable and more available to our individuals across the state of Florida, but particularly to our rural and underserved communities? So I think, like Lloyd was saying, this conversation is very timely because I think as we've gotten through COVID and having some sense of back to normal, telehealth is still an option. And I think it now needs to be a permanent option for the state. And through this conversation of what it means to be providing this in a way of access for equitability for our members, I'm really excited to be part of this conversation and see what comes about. So thank you so much for having me. If you have any questions, I know all of our information will be passed out, but I'm glad to be here.
Thank you so much, Sarah, for sharing the work that you're doing. Kendra Sier is the president and CEO of CommunityHealth IT at NASA. And Kendra joined us earlier this year at our event at the UN at the 59th Commission for Social Development as our team spearheaded the civil society discussions around the same issue there. Kendra, please proceed with telling us a little bit about your work and in your space and what social contract means to healthcare in your space.
Thank you, Dr. Zia and the Blue Ridge team for inviting our 501c6 Community Health IT to partner with you today regarding this really important inaugural discussion about the social contract between telehealth platforms and consumers. Because there are different models of how telehealth is delivered, who the consumer is can be also different. So for instance, a telehealth consumer could be defined as a patient who's virtually interfacing with the healthcare provider, but also healthcare professionals who are using the platform to directly care for a patient, or even those who are connecting with another offsite healthcare professional could also be defined as consumers. What that social contract is between a telehealth platform and each of those example consumers, it may overlap or it may be different. They may also vary for different communities, sub-communities, and cultures. When I first heard about the topic of this particular forum, I found the concept of a social contract captivating. What first came to mind with me was the simple yet profound expression of Americans' social contract in the United States Declaration of Independence: life, liberty, and the pursuit of happiness. And these are examples of the principles on which our government and identity as a united country are based. The Declaration, of course, isn't legally binding and it doesn't have laws per se, but it's particularly powerful as it defines the moral and ethical milieu from which United States laws and modes of operation are to be shaped from. So at our nonprofit, Community Health IT, the principles that guide our work in helping rural and underserved communities to adopt healthcare technologies are health equity, health access, patient safety, digital inclusion, and local medical community capacity building. So we've been working the past 10 years to address these gaps by leveraging various federal programs and grants, contract work, and the broad network of experts, which includes Lloyd and also Sarah. And these experts, including the others that we work with at the Space Center, with whom we built strong relationships with over the years. So many of the projects that we've done, particularly the ones since the COVID pandemic started, they include telehealth as a strategy. And all of the projects, not just many, but all, follow our guiding principles or what our social contract is. So we believe that any health technology platform should also follow these same principles as well. And this is especially true when they're operating in communities that are rural or underserved for any other reason. The COVID pandemic has caused the world to elevate the importance of addressing the healthcare needs of vulnerable peoples. However, as we fight as a country and a world to extend the access of healthcare wherever people may need it, we have to respect local healthcare businesses and established communities. And they need to be supported by telehealth and not usurped by telehealth. So I just want to make sure that we all keep that in mind, as a globe, as telehealth begins to expand. Thanks so much.
Absolutely. Thank you so much, Kendra. And just a few comments. Kendra mentioned the importance of localizing healthcare. And I think that is why this discussion is, again, so timely, as Lloyd and some of our other partners have mentioned, is because we need to start understanding that, we do have professionals in this space, as Kendra mentioned, who have been doing this for a number of years, addressing the needs and addressing this call to responsibility, from the consumer and provider side. But also, I think it's so important now that we're bringing different stakeholders to the table to have these, very collective discussions so that we may move forward with more meaningful and substantive solutions approaches to localized healthcare. Thank you so much, Kendra. From here, now that we have met our partners, I would like for us to meet our panelists today, and I would ask the panelists each to introduce themselves before we dive into our very guided discussions with our moderator. Our first up is our co-convener of this dialogue, the inspirational Dr. Waqas Ahmed. He is also the founder and CEO of American TelePhysicians. But before I turn it over to Dr. Ahmed, I would like to ask Dr. Ahmed to, speak a little bit about Sherrie Johnson's role, because Sherrie Johnson is not able to join us today, and she is the VP of Business Development at the American TelePhysicians. And if you can speak a little bit about her role, and then I would also like to yield the floor to you to tell us a little bit about your professional space and how that deals with health inequities. Thank you.
Thank you, Ameena. Thank you, everyone. Our guests and panelists and the partners. As Ameena was mentioning, Sherrie Johnson, who's our VP of Business Development, was supposed to give this introduction. Unfortunately, due to acute illness, could not join today. I am founder and CEO of the American TelePhysicians, which is a physician-led digital healthcare and telemedicine company. And we're based in Jacksonville, Florida, but we do have operations not only in the US, but also in the international country. We started our journey with international countries, and then we brought this project in the US. And we have been kind of working with the Blue Ridge Consulting and other stakeholders, and have represented our projects at the United Nations, as well as with the IFC, the World Bank. And now we're obviously focusing on the local healthcare communities, and Florida being our home base certainly is the priority. And the whole American Telephysicians is not only a technology company, but we also provide multi-specialty physician services. And the idea is, as everyone knows, how the healthcare dynamics are changing. And I'm glad that this forum is about talking about disparity, which we will touch base in the question answer session. But as a company, we're building an online healthcare system. And I think everyone knows how COVID space changed the dynamics of the healthcare delivery, and the telehealth model, which is now perceived as the future of healthcare. But it's not just the physician to patient relationship or interaction there. Our company is working, how can we build this an entire ecosystem to bring the care at the doorsteps? And I'm looking forward to kind of have an active discussion on this topic with all of you guys. Thank you.
Thank you, Dr. Ahmed. Our second panelist is Sherrie Williams. Sherrie is the COO of the Global Partnership for Telehealth. Sherrie, please tell us more about yourself and your work.
Good afternoon, everyone. I'm Sherrie Williams. I am the Chief of Operations at the not-for-profit Global Partnership for Telehealth. We're located in southeast Georgia, over near the coast, and we serve the Southeast region. I happen to get to work with Lloyd on a daily basis, as GPT is the grantee for his Telehealth Resource Center. So we're honored to be a part of that wonderful program. A little bit about me personally. I am a social worker, and I have been working in mental health and social work I was counting up the other day, for 23 years. That pains me to say. And over half of my career in social work has been in telehealth. I was a little shocked when I started doing the math to figure that out. I started back in the early 2000s working in the space in school-based health and very rural communities, trying to connect children to very much so needed health care. GPT has been around. We're one of the old timers in the telehealth space. We've been around since the really early 2000s, before telehealth became cool. We were talking the other day with our staff, and COVID obviously has made telehealth front and center in healthcare. And we've spent years and years and years begging people to understand telehealth and to adopt telehealth as part of their healthcare practice. And told we were just going to wear T-shirts that just said "Told you so," because I feel like telehealth has finally made its place, and it makes a lot of sense in the world that we currently are trying to navigate around us now. In terms of social contract, absolutely, GPT has a very strong belief that telehealth is one of the great equalizers, if I can use that term. It does allow those disparate communities and disparate populations equal access to healthcare regardless of where you live. I personally live in a very remote rural area, and healthcare is not easy. Healthcare is not easy for me, and I have transportation. I live in a community where transportation is not very common. So being able to get to quality healthcare has always been a great issue for my community and communities all over the U.S. just like this. So we are pleased to be a big player in the space. We strive every day to make sure that telehealth is being used to support local communities and to support those residents who are living there. So I am honored to be here today, and thank you.
Thank you so much, Sherrie. Our next panelist is Matt McBride. Matt is the CEO of Mend, and he can tell you more about his work. Matt, can you please go ahead?
Yeah, and thank you so much for having me today. And it's great to participate on the panel here. Mend is a complete software platform with telehealth and patient engagement. So really one of the few platforms that is built from the ground up to span both virtual and in-person appointments. So as we transition to this post-pandemic society or world, there's a transition happening from brick and mortar to click and mortar. And I think that's where software providers like MEN come in. And so we've been doing telehealth since 2015. We have almost 4 million patients on the platform. And so we help organizations of any size, whether they want to do patient self-scheduling, digital forms, reminders. We have AI to help with no-shows and late cancels. And then all of the other smaller types of patient engagement features that an organization might want. So secure messaging, bulk notifications, et cetera. In terms of our social contracts, there are definitely several. I think first and foremost, we always want to make it as easy as possible for people to connect and reduce those technology barriers. So on maybe the staff and provider side, giving them more single screen experiences instead of having all these different devices to now operate in this digital world. And for patients, just making it simple. You click, you put in your date of birth, fill out forms, click date of birth, connect to your telehealth on any device. So just making it easy. The next is that we always want to provide instant support to anybody. So we don't just support our customers. If there is a patient that needs help with the technology, we have people available within seconds that can provide help to anybody on the platform, even if they just have a question. We are always working to continue to work, bandwidth was brought up. And so I think part of our social contract is to continue to push the limits on what is actually required to do an audio video connection. And so we have configurations that exist today where we can now do video around 30K a second, which is the equivalent of what it takes to do audio, just to put that into a little bit of perspective. And I think we can continue to push, and I think all of the stakeholders are continuing to push so that we can work with less and less and give people more access. I think also supporting languages is big, and the languages that we have lots of different languages with folks throughout the United States, and we have support for all of those with notifications, the website, or bringing translators into calls. And then affordability. We have a free telehealth option. We have options that are affordable for small all the way up to enterprise. I think the cost of the software is depending on if you're a nonprofit, what type of healthcare organization you are, you may not have the budget for some of these expensive solutions, but we can provide that enterprise grade solution. And then finally, I think we always continue to try and challenge this assumption that there's populations that aren't capable. And I think the assumption should be that everybody is capable, because we see it all the time. And we have large percentages of users over the age of 55, over the age of 85. And I think time and time again, we see that people are very capable if we make it easy. And I think if we just start with that assumption, we don't even try to bring that care to those that might need it.
Thank you, Matt. Thank you so much. Next, we have David Walker. David is the CEO of Weems Memorial in Florida. David, I did my best to try to pronounce Apalachicola. Here we go. So let's hear it from you.
Well, thank you all for inviting us. I think this is a great discussion, regarding social contracts for telehealth. My name is David Walker. I'm the CEO of George E. Weems Memorial Hospital. We're a 25-bed critical access hospital located between Panama City, Florida, and Tallahassee, geographically isolated area. We have two rural health clinics here in Franklin County, as well as manage the county emergency medical center and services. One of the things that we're doing here, one of my main objectives is really to keep healthcare local, reduce travel time. We're an hour and a half from the nearest tertiary hospital. This discussion is very important to me because we are a geographically isolated community, underserved community, rural population, high poverty rate. And so we want to make sure people in our communities get the quality healthcare service they need. And I do believe that telehealth is an option for us. I believe that that's the game changer here for rural communities. My background, I'm originally from Fort Lauderdale, Florida. So I come from the inner city. And before I moved to Apalachicola, I thought we needed more services, in our inner city. I worked in the behavioral health model, substance abuse mental health administrator down in Fort Lauderdale, and I kept begging the state for more resources. But when I moved to Apalachicola, I really saw that, the lack of access to care, here. And then what can we do to find solutions for that? And I believe that telehealth is the gateway for that. We've entered a partnership with one of our largest healthcare providers in the Big Bend region to coordinate with us and provide some telehealth services for our hospital and our rural health clinics. When COVID-19 happened, it kind of pushed us out in the forefront. My background is public health, and so I'm used to dealing with pandemics, and we had to begin to think differently. How can we get services to our consumers? Or how can we link up with different specialties in different areas to provide the care in our communities? Because an hour and a half drive time for services is a lot. Usually it's about a 6-hour time frame, once you drive and take care of your business in a bigger city and then drive back. So we had to really leverage our resources, with our local partners here. And one of the things, Richard Lewis will talk about this a little bit more, partnered with our EMS to provide a community paramedicine program and to think outside the box in providing telehealth and telemedicine services to our community. So I'm a big proponent of this. I think this is a game changer for isolated communities and rural underserved communities. Like one of the panelists said earlier, I think it's the great equalizer, really. It's the great equalizers. And I think we need to find more solutions and highlight those solutions and advocate those solutions as opposed to highlighting the barriers why it cannot work. My philosophy is, what if it can't work? What can we do, to bring these solutions to reduce travel time for our local consumers here in Franklin County? So I'm very excited about this. I'm very excited about meeting a lot of different panelists, and was looking forward to other meetings outside of this, so we can bring telehealth services to the rural communities. And like I said, we're a poster child for this particular project here. So thank you all for having us. We're looking forward to the conversation.
Absolutely. Thank you so much. Up next is Richard Lewis. He is the Franklin County EMS Director and closely aligned with Weems Memorial, and of course, David Walker, who we just heard from. Richard, please tell us more about your role and your concept of social contract in healthcare. Thank you.
Good morning. Thank you for having me. My name is Richard Lewis. I'm the Franklin County EMS Director with Weems Memorial Hospital. Early 2020, we started to develop a community paramedic program. During this development, we did our community health assessment, and what we found is there was a large disparity in individuals receiving primary care. At the time, we had 2 major clinics in the county, so our response to this is we got with the clinics and with the hospital and developed a telehealth program that our paramedics would actually go to the different houses, to these individuals that wasn't receiving care, and we take the equipment, so if they don't have internet or if they are having issues connecting, we provide that for them. On top of that, our paramedics are also on scene. We have the protocols available to provide interventions that the clinic normally would. So if they needed a 12 lead or medications or different interventions, we was there for that. So that's a program that we're developing and we're trying to expand as we go. And the connecting with the patients has been a really big thing for this community. There's a lot of patients that wasn't receiving care that we are seeing on a monthly basis or every other week, and it's definitely helping a lot of people in this community.
Thank you. Thank you for sharing that with us. And last but definitely not least is our panelist, Teresa Barton. Teresa is the president-elect of the Florida Council on Aging. Teresa, we are certainly looking forward to hearing from you. Please tell us a little bit more.
Okay. I am the incoming president for the Florida Council on Aging, but in my day-to-day existence, I'm also the CEO for a nonprofit organization in Jacksonville called Aging True. Aging True serves seniors and frail and disabled individuals and caregivers throughout Northeast Florida. We provide, primarily, we have 4 areas of programming that we provide to seniors. Housing, we do affordable senior housing in downtown Jacksonville. We actually have 642 senior housing units that we provide in downtown Jacksonville. We do also nutrition services throughout Northeast Florida. We serve more than 1,800 home delivered meals in 2 counties in Northeast Florida. We provide extensive social services. We have more than 30 program offerings that we provide primarily to homebound seniors, although we do some center-based services, and we have an adult daycare center. And then our last area is in healthcare. So I'm very interested in this conversation. We have a home health agency. We also have a mental wellness program that does some telehealth. So it's really interesting to me from a provider perspective to be part of this panel. Although today I'm actually representing Florida Council on Aging as their incoming president. The Florida Council on Aging represents businesses, government, and academic institutions and individuals who are interested in furthering the information, education, and advocacy for seniors throughout Florida. It's one of the oldest senior advocacy organizations in Florida. It has a broad and diverse membership and is a collaboration that is completely devoted to senior issues, concerns, and advocacy. FCO does have a position on digital healthcare and telehealth. Its position is consistent with all of the other programs and services that are provided to seniors throughout Florida. It is the intention of FCOA that all of the services and programs seniors receive should be accessible, affordable, and sustainable. FCOA is particularly interested in healthcare solutions and technology that reduces the disparity in healthcare access and in healthcare options that seniors are afforded in Florida.
Thank you so much, Teresa. At this point, I would like to turn the event over to our discussion moderator, Bill Ray. As mentioned earlier, Bill serves as an outreach development consultant at Blue Ridge Impact Consulting with us. And Bill, would you like to briefly introduce yourself and also guide us into the next phase of the event that everyone is waiting for? Thank you.
All right. Thank you so much, Ameena. Like Ameena said, my name is Bill Ray. I am an outreach consultant for Blue Ridge Impact Consulting. I've been doing community-related work probably since I was 11, so this is something that comes very natural to me. You know, what I love about this panel is it seems like everyone has the right heart to be doing this work. Let me say this. First, I want to thank Dr. Ameena Zia, president of Blue Ridge Impact Consulting, and Dr. Waqas Ahmed for allowing me the opportunity to moderate this event. I just want to start here and let you guys know, like, you know, telehealth is something that, you know, has really been pushed to the forefront. And I just want to set the stage before we get into the discussion. I have spent a tremendous amount of time over the past month really just educating myself on the importance and significance of telehealth. And just actually a couple of days ago, May 17th, there was an article that came out on TechCrunch titled, "Should Startups Build or Buy Telehealth Infrastructure?" And this is by a lady by the name of Natasha Mascarenhas. And it begins, digital health in the US got a huge boost from COVID-19 as more people started consulting physicians and urgent care providers remotely in the midst of the lockdowns. So much so that McKinsey, of course, one of the largest consulting firms on the planet, estimates that up to $250 billion of the current healthcare expenditure in the US has the potential to be spent virtually. The prominence of digital health is undoubtedly here to stay, but how it looks and feels from provider to provider is still a debate among sector startups. But for providers who want to deliver care virtually across the country, it's not as simple as adding a Zoom invite to an annual checkup. The process requires intention at every step, right from the clinicians delivering remote care to the choice of even payment processor. Now, I thought that would be just a good way for us to understand, and for anyone who's watching to understand the magnitude of this space. And I hate to call it a market. I'd rather call it a space because, I don't like to equate people's health, in financial terms, because it really is about the social contract that we all share with each other. And, you great folks, this is a wonderful panel. I'm so glad to have you on here. This is an education for me, and I look forward to this discussion. So I want to start out with going to Sherrie Williams, who is with Global Partnership for Telehealth. It's expected that the members of the healthcare profession will address problems of individual patients, but because of their role as a healer, there is also an expectation that healthcare concerns itself with issues of importance to the society as a whole in general. Do you think that telehealth has a role in the promotion of public good?
So, of course, but first, let's just kind of do a level set in terms of at least how we at Global Partnership for Telehealth think of telehealth. Telehealth is not a new healthcare service per se. It's an extension of that provider. It's just a service modality. Rather than, getting in our car and driving to the brick and mortar, now we're picking up our smartphones or our laptops or whatever and seeing the doctor. So it truly is just an extension of that provider in most cases. So to this end, telehealth is providing access to more and more of our population. In our company, we have the privilege to work all across the Southeast United States and even internationally, being able to provide health care to those populations who did not have health care before, or who may be in situations where maybe they are a disparate group and there were no providers in their community that knew anything about working with that group. Being able to bring in specialists into these communities to work with these populations is huge. And I don't think that can be underscored enough. Going back to the whole thing that I heard Kendra talk about, heard several of us mention, is the concept of telehealth being a part of a local medical community. Whether you're in, downtown, big city, Miami, Atlanta, wherever you may be, you are in a situation where there are lots of providers available. That doesn't mean that you still have access to them, though. So telehealth in that way is helping to get, even in urban areas, healthcare to those patients who can't afford an Uber ride, who they don't have money to hop on the train to ride to wherever they're going. So in that case, it makes so much sense in an urban area. When we compare that and contrast that to a rural area, we may have one or two medical providers in a community, and those medical providers really rely on that community to keep their doors open and their lights turned on. I see time and again, very large telehealth corporations that are bringing providers into a community, and the provider has no invested interest in that community. So they're seeing patients that normally would go to that local medical provider. When we go into a local community, we get a lot of pushback from the local medical providers because they are fearful that telehealth will come in and undermine their patients and their base. I don't know that that happens on a large basis. I think there is the potential of it. It's an unintended consequence. And I think, you know, as we are working in telehealth, I think it's our responsibility to make sure that we are doing what we can do to support that local medical community rather than bring in outside influences who may unintentionally erode that system. When we're thinking of economic development, even in communities, as healthcare leaves a community, so does industry. And industry is not going to move into a community that has zero healthcare. So as we are thinking about telehealth, and as we are thinking about implementing telehealth in, you know, more places and different places in different creative ways, I say let's continue to think that way, but at the same time, let's really weigh out those unintended consequences, and let's do what we can as an industry to really support what is happening in that community. If we already have populations who aren't accessing care, what now happens if they can't access the job because everything leaves the community? So it all kind of balls into one big ball of wax, and one affects the other. So I think we really have to consider that as we're going in. But do I believe that telehealth affects the public good? Absolutely, in so many ways.
Absolutely. Any other thoughts on the significance of telehealth and its impact or influence on the overall public good? I'll take maybe one or two more.
Yeah, Bill, this is Matt. I think maybe what we think about telehealth from what you've experienced to you know, maybe what you see in commercials and whatnot. I think it's not just you know, you're talking with your doctor to get a prescription for, you know, a scratch in your throat. I think the different types of situations that really exist out there, and the ability to do public good. For example, we have telehealth kiosks in shelters for abused families, where it may not be safe for them to leave that area, and telehealth can be used to deliver care into those shelters. I was raised by a single parent. If you imagine managing kids and work, and how would you maybe get therapy? And we have therapists on the platform that are able to offer more therapy around the clock to fit those schedules so that people can actually get care. We have tons of children throughout the foster care system that are receiving, you know, various services through telehealth. We have homeless populations. I think there's just so many more use cases than maybe we ever thought were imaginable if you really start to drill down into what you know, a lot of amazing organizations are doing with telehealth.
All right. Well, I keep hearing, you know, a lot about you know, getting healthcare services to the underserved. And, you know, I think the thing that we've seen throughout this country, especially over the last several years, is a growing discussion about disparity within different communities. So this next question goes to Dr. Ahmed. Is there a way that telehealth can help eliminate some of those disparities that over the last few years we've been talking so much about?
Thanks, Bill. So yeah, I think this question is actually very core to my heart too, because a lot of time we think the disparities comes in mind, and we start thinking about, you know, patients living in the rural areas or underserved community. But let me tell you, is even the urban areas have that population, and that population, you know, those may be immigrants. I know my mother and my parents, you know, we visit me, they don't have insurance, and finding affordable healthcare had been such a big challenge. And that's like when I started this company 4 years ago, these are the challenges which, you know, were impacting me as a son of a caregiver of my you know, my parents who used to come here. But the same disparity also lies people living in the senior living communities, because guess what? I mean, and COVID actually flared that, because a lot of those patients who live in the nursing home, they don't have access to specialty care. People who have language barriers, and then so in reality, there are 3 A's which I think everyone's talking about: access, affordability, and awareness. And so when we started this company 4 years ago, I thought, like, what's the way to, you know, solve all these 3 problems? One of the big problems in the US we have is lack of price transparency, the surprise bills, right? So this is, and that's why I think people, especially people who do not have insurance, or even they have insurance, that's one of the biggest factor. People, I personally got my own bill for MRI, $1,800. So we took a 3-step approach. Luckily, we had a team of multi-specialty physicians. We established our own IT team, and we built 2 major platforms. One was a marketplace project platform where we contract with a lot of already existing healthcare service providers like Quest Diagnostic nationwide coverage. We contracted with them for very affordable labs rates. Even like a very simple blood test CBC, just $9. So like, I have seen that bill for $120 for that, just CBC. Similarly, we contracted with the MRI, like 900 radiology centers. And then we thought, look, we also need to have doctors involved. So we built our own telemedicine EMR platform named Smart Clinics. And we integrated these 2 platforms, so to give a complete online healthcare system. So no matter if the patient is in the rural community, or if the patient is in the nursing home, or patient does not have any patient family language barrier, they all are using this platform, and they can actually not only get access to primary care as well as specialty care physician, but then if the physicians now order any of the ancillary services or any procedures, they don't have to actually worry where to go and find those services at affordable rate. So I think that's exactly what the model concept of telehealth is, to build a complete online healthcare system. And taking it to the next step now, what we did, because we kind of proved that concept utilizing the community resources, because healthcare is local. So each city or each place, we kind of contract with those local service providers to get integrated in our platform. And then because we have built this technology platform, now we're working with the healthcare systems to give them the whole technology platform, so they can actually utilize this technology platform to offer their services to their patients, because it's impossible for just one group of, no matter how large the physician group is, to provide the services. And keeping in mind healthcare is local, so they're not using technology platform to provide that service to their patients who kind of need it the most there. So and I think the other thing which language barrier has been a big challenge, because people who especially are immigrants or Native Americans there. So luckily with telehealth can solve that. In our own technology platform, we also enabled the interpretation service. Immediately within 30 seconds, you can get interpretation service. And that's, I think, the beauty of the telehealth, where it's very hard to find otherwise. And even people who cannot, have, or do not have access to the internet, that's where this technology to bring and convert the local clinics into a multi-specialty teleclinics. I think that's where now we're working with a lot of primary care organization, as well as some of the organizations, to kind of convert their clinics into multi-specialty clinics, because we have such a pool of the specialty physicians. We can bring those specialty services at the doorsteps. So, I think that definitely the COVID did kind of highlighted those gaps. But I'm glad that actually the legislation changes did help telemedicine companies and the platform companies to kind of grow. And I think the big need right now is moving forward that those reimbursement for the physicians or those platforms there, they continue, because I mean there's there is kind of some concern in the physician community right now, like, okay, is that telemedicine reimbursement going to continue or not? I think now we can say, all the leaders and all this, they need to work on that, make sure that what the journey we have started, I think that there needs to be a push to take to the next level and have more and more physicians adapt to it. And then naturally that will lead to the patient's adoption. Thank you.
All right. Well, I'd be interested in, the hearing from the panelists the other panelists who also have implemented telehealth programs. What have you done, or what have your organizations done to directly address issues of disparities, or what do you foresee doing in the future? And you can just jump in.
This is Teresa Barton. As I said earlier, we actually have some telehealth that we do through our mental wellness programs. One of the things that we've done to help the disparity issue is we've actually obtained some funding and grants to purchase additional hardware for the patients that may need them in order to be, and even gone so far as to do some Wi-Fi, payments in order to have the patients that really need the service have that available to them. We've done it on a limited basis. We have right now, I think, about 22 patients that we're actually assisting. Most of our patients, interestingly enough, either have a smartphone or some kind of technology that will allow us to do what we need to do virtually. But in those instances where they did not have the technology, we were fortunate to get some donations and partners who were willing to assist us to do that.
Yeah, and I think one of the things, for so long, technology was always listed as one of the barriers when you started looking at telemedicine implementation. And I think Kendra, noted earlier, it's really about, there's different avenues, different ways you can look at it. Who's the patient, for example? When you start looking at direct to consumer and you look at direct to patient, and still a lot of kind of that hub and spoke model that's going around. More and more, technology has changed, and it's made it so much, I guess, easy. It's made it easier. It's made it, I guess, a little more doable, especially when you start getting into that direct to consumer kind of model, to where a lot of patients are just using smartphones or tablet devices, or their computer at work. So technology is not, I don't want to say it's not a barrier, because I think one of the things we saw during COVID was that, there's still a population of people who struggle mightily when it comes to technology. In the community that I live in here, last year when COVID and everything kind of happened, we actually cut school because they surveyed our families, and we just didn't have enough families with the technology to be able to do the virtual learning in their households. And so our kids cut school. So my 7-year-old, for example, at the time she was in kindergarten, she missed half of a kindergarten year in school. And so technology it's still a barrier to some degree. But, whereas used to a telemedicine card, or to get started in telemedicine, it would cost maybe $30,000 for some of the equipment, that's no longer as much of a barrier. There's still a barrier from a broadband standpoint. And then I think sometimes from a usage standpoint, and that's something that we still have to take into consideration. And so just some thoughts there.
I know in the state of Florida, the Florida legislature, they passed a bill regarding broadband. So there's a lot of conversation on that, on that issue. When you live in rural communities, isolated communities, at one point, technology may not be a barrier for you to use your phone, but then it may be also a barrier for you to get that healthcare. I also think about, the physicians, the reimbursement piece of it. There's a lot of talk that, hey, the reimbursement for telehealth may go away. We need to make sure as local leaders, statewide level, that we push for that, to keep it in the forefront. But those are some different things to try to remove those healthcare disparities, because we do see it, in rural communities in different areas, of our lives, people that we deal with and people that we see and live with every day. But we have to, think of solutions to create, to alleviate those barriers of disparities.
Yeah, and I think something we have to think about too, and I've said this for years, technology has a way of inserting itself into our life, kind of to a degree to where it almost, it's I guess intentional, unintentional maybe, but we just adapt technology and adopt technology in every aspect of our lives. Because it's just something we do, whether it's in our vehicles, now our homes, with connected devices in our homes, whether it's our refrigerators and our microwaves and all these things. The issue we faced, though, was we were a little more hesitant to adopt the technology into the healthcare space. And some of that was driven by slow adoption from legislative standpoint and reimbursement issues. And so, but at some point it's going to happen. And so there's no way that you are going to stop the technology from inserting itself into the healthcare field. There's no way.
I agree.
And so at some point it's just going to happen. It's a matter of when does it happen? And I think that's what we're seeing right now.
Absolutely. I think that a lot of it has to do with trust. Like, how do you build trust in this new process? The social contract is about trust. You want to have trust between the patient and the provider. That's so important. And folks are so used to having that one-on-one with their doctor. And sort of moving from that is going to take time, because people have to be able to, not just trust the diagnoses, the input, the recommendations that they're getting from their doctors. They have to trust that they're providing the information correctly, to the doctor. Maybe the doctor is asking for something and you're not able to provide it correctly because you're not, there in the room with the doctor. So I think there's so much that has to happen to sort of bring that relationship into the virtual space. And I'm going to, sort of direct this to Teresa Barton at the Florida Council on Aging with respect to telehealth, because you were talking about some of the things that your organization was looking at implementing. And around this idea of trust, can telehealth build trust? And if so, how, without the standard type of one-on-one relationship that people are so used to when it comes to their physicians?
Yes, well, first I want to thank you for giving me such a simple question. Trust is probably, we are living in a very cynical time right now. I think everybody would agree that, it is an ever increasing disinformation, information campaign almost daily. So trust becomes a very, very big issue for everyone. Particularly for the population that I love, that are near and dear to my heart, seniors. Older individuals have an additional kind of play with it. Technology is new to us, folks. Okay, we weren't born with technology like my children and my grandchildren. We were born with. I used. Believe it or not, I used a typewriter when I went to college. So in that kind of evolution of technology, which you alluded to earlier, and so true, that we adapt and we incorporate it in, but with today's culture, trust is just going to be an ongoing issue. I think with every aspect of business, particularly with aspects of where it's something new and different, like a new a new technological approach. But I think there's some basic things that you can do and follow that will create a more trusting environment. Some of the things that we've discussed at FCOA that has to do with building trust has to do with most importantly, honesty. Providers of services need to be honest about what they're providing. You know, I always say, you know, you've got to under promise and over deliver in all of the services that you do. And that's just as true in technology as it is in Meals on Wheels. I mean, you really want to deliver better than what you're promising. And I think sometimes, especially if it's something new and lots of bells and whistles, there's a tendency sometimes to overestimate what the capabilities and capacities are. So I think that providers should always be aware of that. The programs, and you alluded to it, Matt, earlier, they need to be simple, understandable, things that people can do that they feel like that, you know, they're empowered and that it's not being done to them, or it's something that they get lost in the very beginning. So keeping technology as simple as possible for and I would say whether it is a surgeon or one of my seniors, they still want it to be as simple as possible when they're using the technology. Everybody does. Also, make sure that, and you alluded to this, Matt, communication. It's all about communication and with the individual, whoever the client is, often, and giving them the support and assistance they need frequently. I think that sometimes we miss the mark when we don't communicate, give feedback. You can't, just give someone a feature, walk away and expect them to constantly use it and never have a problem. And, so you've really got to build in support, and not only support, but just communication. I think to build trust, when you come down to the basic equation of trust, has to do with communication. We've built a system that in many ways is a face-to-face communication in healthcare. It's really not about the face-to-face, it's about the communication. Is that communication still flowing? I've heard as many seniors complain about going to their doctor and not getting to spend more than 10 minutes with their doctor, as I've heard them complain about using telehealth to see their doctor. In fact, I've had more positive feedback from my seniors about telehealth than I have about personal visits where they feel like they're just a cog in a wheel and they get moved along too quickly. So I don't think it's really about the face-to-face communication as much as it is about the quality and the quantity of the communication, whether it's virtual or in person. And I think that's what the pandemic taught us. We had to default to a lot of virtual communication among staff, among volunteers, and among our clients. And what we found is that when we communicated consistently and kept following up, that was the most effective thing that we were doing. It wasn't about whether or not we were seeing them face to face, but it was about making sure that we were communicating and having their needs met in as effective a way as we could possibly do through this. I also think that collaboration with local providers and programs, and think outside of the box, and because we see ourselves as a really big provider of healthcare services in the community, although I'm not sure that the hospital groups would see us as a big provider, but there are lots of agencies out there that are providing healthcare solutions for people and are anxious to collaborate and partner with telehealth and be part of the solutions that are afforded to, especially for seniors. Our population tends to be that disparity group we talk about. And the one thing I didn't hear was the homebound, which I think that Dr. Ahmed, you alluded to it, that there are a lot of seniors that are isolated, even in downtown Miami, because they are frail and they are homebound. And that really creates a lot of isolation. And they need more than just virtual. Virtual can partner, but there are a lot of boots on the ground out there that are willing to partner with virtual presence to make sure that things get done for people as they need to be done. And I honestly see that as being the most effective use of any kind of telehealth or technology that we deploy. It's a wonderful tool, but it is a tool. It's not the solution, but it's a great, great tool for the solutions to these problems.
Actually, you mentioned Dr. Ahmed. I wanted to take it over to you, and it sounded like you were about to say something, but I wanted to get your input on how you are developing trust in how you interact with patients and clients.
Thanks, Bill and Teresa. Exactly. And I think I also want to give from the physician perspective. I think on the patient side, the biggest trust, absolutely, first thing is to, for continuation of care. What happened is when the telemedicine company started, it's starting more like an urgent care where, it's like an Uber model. You're, seeing one physician and you may not see that physician ever in your life again, and but I think that dynamics are changing, especially when it's come to specialty care or primary care. The continuation of care with seeing the same provider is definitely a vital thing. But to second part is now, even though you see the same provider, what Teresa mentioned is absolutely right, that you also need to spend time with your patient explaining that, right? And I think what I love about telehealth is that you can also involve the family members, with a lot of time if there is kind of understanding barrier, especially in the senior population. The family involvement is very important, and that's how the telehealth, even your family member may be living somewhere else, but you can involve family members in that virtual meeting. The third is, from a physician perspective, I think what we are seeing in the offices that, as a physician, you really don't get too much time to spend on the patients. It was, unfortunately, from the billing perspective, because we as a physician were dragged into kind of making sure our notes are completed. We are charting those components, which were kind of not related to patients' actual condition, was more like, making sure all the billing and everything. You can just imagine, like, sometimes you're documenting stuff which is not pertinent to that actual condition there. Luckily, that has changed, and I think now CMS kind of have revised. So that obligation for the physician to document those irrelevant part has gone. So I think there will be now kind of more time for physician also to spend with actual patients about talking about their conditions there. So it was a three-pronged approach, which I think telehealth definitely can improve the experience.
All right. Well, okay. So we've talked a little bit about the trust piece, which I think is extraordinarily important. And part of, trust is for patients to feel like they're getting the most competent professional medical services. So this question is for Matt McBride of Mend. How, as someone in this space, do you go about ensuring the competence of the people that are, say, a part of your platform? What standards have you established for education, for training, and practice methodologies? And how do you share those practices? And actually, let me add this one thing. Healthcare is so essential. So I think about healthcare and technology. Obviously, on the technology side, you might have platforms that are interested in, protecting, whether it's through copyright or through patent or that sort of thing. You get where I'm going with that? Like should companies in this space, hold on to certain things that really might be about the improvement of the community and that social contract that we've been talking so much about?
Yeah, I'll circle back to the intellectual property question there. I think first and foremost, we are a software platform, and so we can definitely guide, whether that's through the software or whether that's information that we are providing to somebody that's implementing, whether they've sort of dip their toe in and sort of tried it and now they want to make it bigger, or maybe they've never done it before, or maybe it was, you know, just pandemic phone calls. So we can definitely help them with you know, best practices and workflows, and you know, kind of give them everything that they need to see the patient at home. You mentioned that TechCrunch article where it's not just the video, there's paperwork and consents, and there's payments, and there's maybe I need to get the person a doctor's note after the visit and schedule follow-up. So there's a lot more than just a video connection there, but we do provide live trainings. We have self-guided courses. We of course have the instant support that's available to everybody, even patients. We help customers around any sort of legal, security, compliance types of issues, so that they think about those things and have the right things in place, you know, for their organization. And then we also have a you know, telehealth playbook, and I'll touch on a few of these items because even if you're doing telehealth already or thinking about implementing a telehealth program, I think these are going to be good buckets to think about that we share with our customers. The first, I think, is developing clinical protocols. So when is it safe to offer telehealth? Maybe it's for medication management, follow-ups, to go over lab results, offer therapy. So we encourage customers, when is it appropriate? When is it safe? There are a number of different operational considerations to think about, but I think workflows are probably at the top of those of the list there. So you know, typically we'll see scheduled appointments. So do you just want to meet directly with the patient, or do you want a workflow where maybe they check in, get transferred to the nurse, to the provider, get transferred to check out? You have different ad hoc type workflows. Something a little bit more urgent pops up and you need to, you know, get with that patient right away. And then maybe there's different workflows around on-demand, kiosks, group appointments, so on and so forth. So we help with you know, the different operational considerations. Another point is, you know, scripts for staff. When you're booking that appointment, you can help set expectations. Make sure that the person has what they need, set expectations, what to expect for their visit. We also communicate those things in our notifications just to help. How do you get help if you need it? What should you expect to connect? All of those things. So we can help customers develop scripts for their staff when they're booking those appointments. You know, setting up a proper physical space, whether you're at home or the office, is another one. There might be different standard operating procedures. You know, how are you going to handle if something is an emergency that presents itself? What if the patient is driving a car while they're connected to their telehealth appointment? How are you going to dial in maybe scribes, translators to the visit? Proper attire, camera positioning, and, you know, HIPAA compliance if you're at home versus at the office. We will also point customers to different billing resources, you know, whether that's, you know, through Telehealth Resource Center or Center for Connected Health Policy. Also, Dr. Ahmed mentioned this, but, you know, getting the other people involved in the care into the appointment. So whether it's another parent, spouse, caretaker, and then we also have there's a lot of great resources now than there was a year ago. So there are a lot of great association resources, readiness assessments, telehealth playbooks that associations have put out, and maybe even, you know, the specialty that you practice in has some more specific criteria on how to do this and do this properly, and we can point people in that direction. And so that, I think, hopefully that helps address the first part of the question. The second part of the question around intellectual property,
And just real quickly, because we're going to be running close on time here, and I want to make sure I get the other panelists with these other questions. So,
yeah, I'll keep this one short. It is competitive, so I think people are looking for ways to maybe protect what they have. But I think ultimately, you think more about, or at least I think we think more about, what are the problems that our customers are having, whether it's workflow or something with the patient or other, and how do we create the best solutions for those problems? So not so much how do we, have patents and trademarks and all these things to block and keep it all for ourselves. I think we think of it more as how do we provide the number one product and the number one service. And I think if more organizations are all trying to do that, there's going to be a lot of great options and solutions out there for everybody.
All right. Well, wonderful. Now let's go to Mr. Richard Lewis, Franklin County EMS Director. And what I want to throw at you is the idea of autonomy in the healthcare profession. The healthcare contract, social contract, really gives healthcare providers the autonomy to deliver the best possible service that they can. My question to you is, how does the industry ensure that providers have that same autonomy or some measure of that autonomy when they're in the telehealth space? And I would actually like to also throw out to those that are coming from rural or underserved areas. How do you make sure that telehealth providers are not blocked by regulation? So, Richard.
Thank you. This is a great question. Honestly, I think it comes down to quality of care and standard of care. If we continue to give the quality of care these patients expect, then we will continue to have this autonomy. When I was first developing our program here, there's a lot of hesitation for some of the physicians and patients to participate in it because it's something new and something that historically EMS hasn't done. When I contacted the Florida Department of Health, there's no actual regulations on EMS doing something like we're trying to do here. So I worked with the physicians and the Department of Health to try to develop some policies and protocols for us to do what we're trying to do to get that primary care out to the public, people that can't get in under normal circumstances. By doing this, we are setting some regulations, hopefully in the future, we're a roadmap for people to follow, as well as trying to improve the quality of care and learning from our mistakes as we go. And I really think that by improving this quality of care by every patient we see, that's going to give these physicians, these primary care, the autonomy that they currently have.
And then just to piggyback on the question, how do you ensure that telehealth providers not blocked by regulations or other items that would prevent them from having that autonomy in a rural health setting? I think, as a CEO of the hospital, we look at our protocols, different things that we have in play and say, okay, maybe we need to tweak that a little bit, to meet the needs of the communities, to receive telehealth. Then the flip side of that, is having meetings with our senators, local senators and representatives, that make regulations and laws, throughout the state. So meeting with them on a constant basis and telling them, hey, here are some of the barriers that we're facing because there's regulations out there. And then inviting them to know that, hey, you serve a lot of rural counties, and if we're having this barrier with this regulations, your other rural counties are probably having the same issues, and then they'll take that and address it. So I think it's constant communication with your local elected officials, statewide officials, and then as an organization, looking at your policy and protocols and procedures. What do you have in place, that is creating that barrier there?
Real quick, I'd be interested to hear maybe from a couple of you real fast, like what are the top impacts that you think will be had on the autonomy of physicians when it comes to telehealth?
I think the whole landscape of what is happening with telehealth. If we look at CMS rules, if we look at some of the professional association rules, I think everybody's struggling a little bit right now. Prior to COVID, it was a very much very tight grasp on telehealth, and providers can do this, they can't do that. And there were some pretty hard set rules. Now with COVID, suddenly there were a billion waivers put in place, and that's almost as scary as having too many things put in place. So you have no movement or you have complete freedom of movement. I think the environment will come back to level at some point. I do not think we'll see the tight strains that we saw previously. I do think some of the waivers and some of the things that we're currently see that gives a lot of freedom is going to start realigning itself. A couple of things with telehealth, this goes for the patient and for the provider side. Just because you can doesn't mean you should. Telehealth allows us all this wonderful freedom. If I'm a patient and I wanted to see my doctor standing in the middle of Publix grocery store on aisle 3, I technically could do that. Is that fair for that provider to put that provider in that position? No, it is not. And likewise, the provider, if they choose to see patients, sitting at their favorite coffee shop or wherever, is that okay? No, it's not. So I think there's a huge judgment, both on the provider side and on the patient side, that we really have to start balancing in respect to each other's privacy. But in terms of legislation, I think it's going to be very interesting to see where the rules and regs go. I think we've just begun to see a little bit of rollback, and it'll be interesting to see where that rollback stops and where the freedom begins.
All right. Well, I'd be curious as we get closer to wrapping up here. David Walker, CEO of Weems Memorial. Given the last couple of minutes of discussion, how do we make sure that telehealth stays viable, as a service? And I guess even beyond that, how do you advance the idea of telehealth into the lesser served communities, Black community, the immigrant community? Unfortunately, we're running short on time, so try to limit it to maybe a minute or two as we wrap up here.
Yeah, thank you for that quick question. I think we must advocate, the advantages of telehealth to the minority and immigrant communities, especially the Black community, due to the lack of choice in healthcare because of previous missteps. I think we should highlight, the reduced travel time, the increased access to care for them, and the waiting times, to see a physician. I think one of the things that probably had hindered, telehealth from being accepted in the Black community is that, the community think that, there's something more, that would happen to my information, once I give it to that physician. But I think we just need to begin to advocate the advantages of telehealth. I think from a physician side, the physician needs to spend more time with that patient, especially the immigrant or minority patient. And then that patient can begin to tell their story to their community. Hey, I had a telehealth visit. It was very great. My physician spent a lot of time with me. Then I didn't have to travel an hour and a half or a 2-hour drive, for that visit. So I think we need to highlight the advantages of telehealth, and then we'll begin to build trust as many more people in our communities begin to use it more. That's as quick as I can go.
Absolutely. No, that works. Definitely appreciate it. I'm sure we could all talk about, some of these issues for a long time, but let's wrap up here. And I would like to do a quick round robin. And you can just go one by one. If you'd like, you can go in the order that we introduced you. Is telehealth, a benefit to society? I'd say give your thoughts real quick, a line or two about what you think are the greatest benefits to telehealth and the greatest challenges to telehealth.
So maybe I go first, or okay?
Yeah,
same. So I think certainly affordability. I think cutting the cost of the transport, and also the whole ecosystem, that definitely bring the affordability. And second thing, obviously improving the access, especially the specialty care access there. I think that's definitely very, very much needed. The big challenge is the regulations part. And just to allude that question Sherrie was mentioning, certainly regulations are lifted, but I think from a physician's provider's perspective, I tell you, we're still very scary because A lot of those, every state has a different dates, expiration date, and honestly, no one knew when those dates expired. So you kind of struggling whether you're still able to do a cross-state telemedicine, and also the local states regulation. For example, just quick example, Georgia had this regulation that the physician cannot prescribe more than 3 days of any medications. So if the patient needs antibiotic for 5 days, you literally have to call in twice. So I think those regulations, which some, honestly, I would say it doesn't make any sense, but they did existed there. So hopefully those regulations now hopefully will be eased. And I think that will kind of gain trust of the physicians and will definitely help more engagement and adoption.
All right, who's next? Round robin. Greatest benefits, greatest challenges for telehealth.
I'll just quickly answer. Absolutely, the benefits. I think they're very obvious. Access to care. I think done in a responsible and thoughtful way, telehealth can really begin to close disparities and kind of make healthcare more equitable than we've ever seen it in the past. So absolutely, full steam ahead with telehealth.
And I'll just jump in. Telehealth is the key to increase access to care, to provide a level playing field for geographic and isolated underserved areas here.
And I agree. Access to care is the #1 benefit, and I think the biggest problem to Dr. Ahmed's point is the regulatory environment and making it permanent and giving people that confidence that it's going to be there so we can continue to evolve it.
All right. Did we miss anyone?
Me. I would add that, I agree completely with everything that they said. I think that it's poised to be a game changer in a lot of ways. I hope that it will develop incredible collaborations and partnerships, because I think that's where the real bang for the buck will come with telehealth and virtual health. And there is still the challenge, I think, of trust that needs to, you need to embed ethics and sustainability in a way that makes the end user trusting of this process.
Absolutely.
And I agree with what everybody else said. There is a big benefit with access to care. And, us reaching out to the people that have trouble getting the primary care, the cardiologist, or whatever else. So,
okay. All right. Did we get everyone? All right. Well, wonderful. This has been an outstanding panel, an outstanding event. I thank you all so much. Healthcare and telehealth is not something that people necessarily think about every day. But, I think it's going to be, at least from all accounts that I've seen, it's going to be the direction that, our country heads in, when it comes to healthcare services. And it's definitely going to be a benefit to reaching out and to serving those underserved communities that we really need to, make sure are, a part of the social contract that we have in this country. So I thank you so much. And with that, I will pass this over to Dr. Ameena Zia.
Thank you so much, Bill. We have certainly covered a lot of ground today in our conversation, and our discussion has been extremely intersectional and has highlighted that telehealth is intersectional as we understand the holistic professional healthcare space. I'm very appreciative of these very robust and real discussions that highlight the passion and commitment and the very people-centric approach to ensuring that there is a viable social contract in healthcare. And we recognize, of course, that in our discussions today that health equity and dignity must include conversations of solutions, accountability, and most importantly, rights for all. And as we heard today, that there is a fundamental right for basic health attention. It is clear that we all have a responsibility to our communities with equity and inclusion at the heart of development. We need to ensure that healthcare ecosystems and all actors commit to identifying, to understanding, and to creating structures and changes and or replacing mechanisms and to set forth goals for scalable progress, like the CEO of MED, Matt, said, and also Dr. Mouth of ATP mentioned, and which is rooted in very much universality. Thank you to all the panelists for your very meaningful and transformative work that each of you are doing in your own spaces in ensuring that there is access to quality healthcare, delivery of healthcare, and also to new approaches to care, while we keep in mind that there is a social contract, there is a responsibility, and certainly the responsibility is very viable as actors in the healthcare ecosystem. And we hope that this dialogue creates more conversation topics locally that can help towards reevaluating policies and rules and regulations, as mentioned earlier, and also current structures. Thank you very much for your time.